Hello, everybody. My name is Marielle Jessup. I'm the Chief Science and Medical Officer of the AHA, but I'm also proud to say I'm a card-carrying heart failure transplant cardiologist. So this is a very brief introduction to the AHA. Our charge was, who are we and why are we here? So our mission at the AHA is to be a relentless force for a world of longer, healthier lives. We have a number of guiding values, and the two that are most relevant for this meeting is that we bring science to life and we build powerful relationships. And that is part of our strategic value proposition, that we view what we do at the AHA as a catalyst to achieve maximum impact in equitable health and well-being. What we feel sets the AHA apart is our brand. We're celebrating our 100 years next year, our science, and our grassroots. We have roughly 35 million supporters of the AHA and roughly 35,000 science volunteers, about 5,000 of whom are very engaged. The pillars of our work, including changing policy. We just celebrated 40 years of our advocacy team, changing systems of care, leading breakthroughs in science and technology, transforming communities, and transforming healthcare. Just a few things on our plate. So the foundation of our work and why the AHA was founded is research. We're very proud to say it pales in comparison to the person that's sitting next to me from the NHLBI. Nevertheless, we're very proud that we've just passed the threshold for $5 billion since 1949. This year alone, we have 1,300 active awards for almost a $500 million commitment for this year. And that involves an awful lot of people, volunteers that help do peer review. And of course, people are always submitting proposals. I should say that Dr. Svati Shah happens to be, and we're very lucky to have, as the chairman of our research committee. Let's talk about heart failure. We have had a Get With the Guidelines program for almost 25 years now, and heart failure has been one of them. Currently, we're in about 624 hospitals and are actively enrolling about 2.5 million patients. We see this both as quality improvement, but also a generation of science, implementation science. So there's almost 143 publications bringing this data set to life. And it's truly a machine. And we're moving from the outpatient arena, the inpatient arena to the outpatient arena. To help our researchers, we've developed what we call our precision medicine platform, which I will call the PMP. This is a highly secure cloud computing workspace equipped with analytic tools. Our researchers can go on in their private space, analyze tools using the analysis tools that are listed here. They can collaborate, view the same data and code, and publish notebooks to share with the research community. We have a long established way for our researchers to share easily with Biodata Catalyst. And what we use this PMP for is not only all of our AHA grantees are allowed to use this, and we encourage them, we actually do research grants around data challenge participants. We just did a shared data challenge with the Association of Black Cardiologists around heart failure and social determinants of health. Our Get With the Guidelines researchers use this because all of our Get With the Guideline data is on the PMP. We have a cohort of women called Research Goes Red, and we have funded researchers there. And then researchers can bring in their own data, including many of the studies that are part of AMP-HF. Our researchers have easily shared their data and access things through the Biodata Catalyst. I also just want to quickly talk about a multi-funder study that we're doing called Implement HF. Some of our funders happen to be represented here in the room. And this is a very large improved patient outcomes and quality of life with the metrics you see, really reducing all-cause mortality by 5% and increasing the number of patients with quadruple medication therapy by 20%. We view this as a learning healthcare system and will engage about 100,000 patients through participating. We're also viewing this as a way to test value and policy. So we are really actually testing a measure of healthy days at home to align with CMS. And we've developed a number of tools for our patients to become more engaged. Next slide, please. This just shows where our sites are. I want to say both for our Get With the Guidelines and Implement HF, we're going out of our way to find sites in rural areas and that are enrolling a diverse patient population. For our Get With the Guidelines, if they can't afford to be in Get With the Guidelines, we actually have generated funds to help them. So diversity and inclusion and representation from all parts of this country are really important for us. And this just shows where these patients are coming from. As I said, we're moving out of the hospital space and into SNFs, assisted living, and home health care. I'll finish by just showing you a couple of examples that are very evoke what we're trying to do in this room. One is by Ambarish Pandey and his group at UT Southwest, where he developed machine learning-based models incorporating social determinants of health versus traditional models to predict in-hospital mortality. He harmonized a number of data sets across the world to prove what we all suspected, that that our predictive models for heart failure mortality will be improved when we take into other variables. This same group also did another one looking at neighborhood level social determinants of health. Again, all of this data was used from Get With the Guideline data and other cohorts and shared on the PMP. And then another group who many of you know, David Cow and Pardeep Jun from Glasgow, really took a enabler user-directed phenotyping analysis of acute heart failure using the BioLink data, many of the sets that we're talking about, and have made a system where the minimal, the data harmonization can work very easily and simply by pulling all these in. So the AHA is here because we're deeply committed to heart failure. We'd love to continue to work in parallel, but we hope our paths cross sometimes as well, because we're very much a collaborative organization. So thank you very much.